Recording in progress.
Welcome, everybody, to another edition of Wildcard Wednesday. It is Wednesday, April 29th, and I am Stacy Buck, President and Senior Consultant at RadRx. So I am back this week after taking off last week. Last week, I didn't post any coding-related content. It was actually Health Information Professionals Week, and I had scheduled a bunch of posts the week before to coincide with Hip Week. And so I decided to give myself the gift of some free time and not create any coding content last week. But I am back this week. I did Coding Tip Tuesday yesterday, and now I'm back with Wildcard Wednesday. So this week I have three cases that we're going to take a look at. I chose three because one of them is like very short and it's a non-vascular case. And then we're going to look at two vascular cases today in addition to this. So the first case that I received, the question that I received with this case, would this be 76000? That would be fluoroscopy. 5038752. The 50387 is the removal and replacement of an externally accessible nephroureteral catheter. 50431 is for that nephrostogram, ureterogram, or unlisted 53899. So this procedure is actually a repositioning of the patient's left nephroureteral stent. So there is no code for repositioning of the patient's for a patient's nephroureteral stent. So in looking at the steps of the procedure, what I would recommend in this case is actually assigning the code 50431 for the imaging that was performed. So we do have a codable service in this report. I don't feel that 50387 would be appropriate, even with a modifier 52, because that's removal and replacement, and that did not occur here. We simply had a repositioning. And then as far as using an unlisted code, I think that's unnecessary to do so. Obviously, using an unlisted code, that's going to cause an issue with, potentially getting paid. It's a lot of work. And really, this is a simple procedure with just the repositioning. And how I look at this is that if there had been another codable intervention, let's say a removal and a replacement or something else that would have occurred, then that imaging is actually going to end up being bundled with that intervention whenever that's performed. We see that the imaging is going to be bundled with, the initial placement, also with a replacement and other services that fall in that category for the urinary procedures, that 50431 component is always bundled with the service. So because we don't have a code to describe a repositioning, I default back to the imaging code, the 50431. And I feel that that's really, good from a reimbursement perspective because it is the work that we did. And it was just really, adjusting the position of the nephroureteral stent. So I think that's sufficient. It is based on what's documented, and it's the easiest way to proceed with this particular case. So my recommendation on this would be to code the 50431 for the imaging that occurred for this particular procedure. It's the easiest and most straightforward way to actually get paid for the service that is provided. Okay, so case number 2, we have a balloon-occluded retrograde transvenous obliteration of gastric varices. So this is the BRTO procedures that typically are coded with a 37241. But in this particular case, we're going to see that the patient has this ongoing bleeding problem. When we go into the paragraph about the indications, it mentions that the patient has the varices with a significant GI bleed. There's multiple transfusion protocols that have taken place. The patient continued to bleed. Interventional radiology was consulted for management of the bleed and to stabilize the patient. And so the patient is coming for the procedure to be stabilized before being transferred. So the BRTO is being performed to stop that ongoing bleed and then stabilize the patient for transfer. So typically a BRTO, if the patient doesn't have, active bleeding, or it's, maybe some chronic bleeding that isn't really, like causing an issue, then you're going to code those with 37241 typically. But in this case, given the extent of the bleeding, the duration of the bleeding, and that they need to do this procedure to stabilize the patient, I'm going to consider this for the 37244 code for the hemorrhage because of that ongoing bleeding. I mean, if the patient's having transfusions and all these other issues and they have to be stabilized, then I'm going to go with the 37244. So it's kind of like a sneak peek of where we're going to go with the procedure code. It gets coded, the BRTO gets coded as an embolization. So we jump down into the procedure itself. The first paragraph is just about consent. So we're going to skip that and we're going to go into the second paragraph there where we see that the physician gained access at that left common femoral vein. So we see that it's visualized with the ultrasound guidance. And then we see that the patency is documented, the concurrent real-time visualization is performed, and then we have mention of a permanent recording as well. So we're going to pick up our 76937 for the ultrasound guided vascular access. So here we have our initial puncture at the left common femoral vein. When the physician does that puncture, that's going to be a 36005 for the non-selective catheterization there. But as we go into this report, when we go into the next few sentences, the catheter was moved. Now in that third sentence, you'll see that it says that the wire was advanced into the abdominal aorta, okay? And then it says exchange was made over the wire for a Cumpy catheter, which was utilized to select the left renal vein. I'm thinking that's probably supposed to be the IVC because we're in the venous system, there, and it mentions the wire was advanced, not a catheter, but if the catheter would have to go through, obviously, the IVC to get to the left renal vein. So, of course, that catheter work is going to be bundled with the selective catheterization work that we are seeing here with the renal vein. And then you see that the catheter also went to that left gastrorenal shunt. So we had a 36011 when the catheter went into the left renal vein, but the catheter went into the shunt, so it's moved more selectively. So now we're going to count that as a 36012. So right now, the two codes that we have for our case are 76937 and then 36012 for the catheterization. Then you'll see in the last few lines of that paragraph there that a balloon catheter was utilized to occlude the antegrade flow. And then it says that the balloon was inflated. And then we see that there's satisfactory occlusion of the antegrade flow to the renal vein. So this is actually going to not be coded as an angioplasty. Yes, a balloon is being utilized, but if we go back to what this procedure is called, it's called a balloon occluded retrograde transvenous obliteration, okay? And that is going to be coded with an embolization code that it's for embolization or occlusion. So that's part of the procedure right there. So at this point, we would already call it the embolization procedure and assign the code. But when we go further down here, we see ultimately in that next paragraph that we actually have the coils that are placed into the actual shunt, okay? So it says attempts were made to pass the wire more approximately to get access to the gastric varices, but because of tortuosity, the vessels, the wire could not be advanced, vessel could not be selected. So they decided to embolize from that particular location. And then you see that the sodium tetradicyl sulfate and gel foam slurry, I'm tongue-tied today, was, inserted. And then from there, it says the gastrorenal shunt vessel was embolized utilizing the coils. And then we have that repeat angiography that occurs there. And then the balloon was deflated and removed. So really the last portion of that prior paragraph and then the following paragraph, that describes that BRTO procedure. And again, I'm going with the 37244 with this because obviously the patient was having a problem with like ongoing bleeding and the patient needs to be stabilized. So I'm choosing the 37244 over the 37241. Now notice I did not note any imaging codes in this particular case. The reason being is that it was known that the patient was going to get this procedure performed. It was requested to stop that ongoing bleeding and stabilize the patient for transfer. So none of the imaging that occurred is diagnostic. So when we go down and look at the final codes for this case, what we end up with is three codes. We have 36012 for the catheterization, and then we have 37244 for the embolization and occlusion, and then we have 76937 for the ultrasound guided vascular access. So at first glance, this looks like a complex case, but it's really not as complex as it appears after you go through it. So That is case number 2. So let's go on to case number 3. So with case number 3, the specific question that was asked, it says, my question is, the consult shows the patient agreed to thrombolysis, but also shows on the plan possible LLE thrombolysis. And then, can we bill angioplasty? So it's kind of like a two-part question here. So we see with this patient, there was a consult before the procedure. It mentions that duplex findings demonstrated extensive occlusive iliofemoral DVT. And then it says the patient would like to proceed with an intervention and is agreeable to thrombolysis initiation. We will plan to proceed with venography today. And then the plan specifically said proceed with venography with possible LLE thrombolysis, mechanical thrombectomy today. So when I read this information, this is telling me that the imaging has to occur before the decision is made on whether or not the physician is going to proceed with thrombolysis. So the other sentence where it says the patient would like to proceed with intervention, how I'm taking that is that the discussion was had, with the patient, are you open to having thrombolysis performed? And so the patient says yes, but the diagnostic imaging actually had to be performed to make that decision. So the patient consented to it, it appears, if necessary, and the physician is saying possible thrombolysis, so no decision has been made regarding the thrombolysis or the mechanical thrombectomy. So imaging has to occur first. So this is going to be a procedure that occurs over the course of 2 days. So on day 1, we see, I'm going to start just looking at that bulleted list to see what we're dealing with. We have our ultrasound guided vascular access, venography of the lower extremity and the IVC, and then we see angioplasty of the iliac veins, the femoral veins, and then thrombolysis that is initiated. So we actually have a couple of different things occurring here on day 1. So if we look at the beginning portion of this procedure, we see that the ultrasound guided vascular access, that we have our documentation requirements met there. So we're going to report our 76937. And then here the access was gained at that left popliteal. When the access is gained there, we have a 36005 for our non-selective catheterization, but that is going to go away because the catheter is going to be moved further. So we're going to drop that code. When we look at the next paragraph, we see that the physician mentions venography of the left lower extremity and then gives us findings for that left lower extremity imaging there. And so at that point, I had noted that should say a 75820. That's a typo, obviously. 75820. The reason why I have that crossed out is because some imaging is going to occur in the opposite extremity. So then we see that the IVC was selected in that next sentence. That would change. That's when the catheterization code changes from a 36005 to a 36010. And then we see that venography was performed of the IVC. We have findings for the IVC. So I added the 75825 for the IVC imaging. Then the physician says that they selected the right iliac veins, but does not specify whether it was the common iliac or whether it was the external iliac. So with that question, I don't know whether I'm going to assign 36011 for the common iliac catheterization or the 36012 for the external iliac catheterization. But you see with that catheter being advanced to the 36010 gets deleted, the non-selective code, and we're going to report the selective code. So I actually would ask the physician which vessel was selected so I could make the determination, is it the 36011 or 36012? With that said, if you are not able to get information from the physician confirming where the catheter was placed, then I would go with the 36011 because I cannot assume that it went all the way to the external iliac there. So that would be my catheterization code choice. And then it mentions that the iliac veins are like widely patent. So it didn't here give findings beyond the iliac veins. And so some may argue like, okay, I don't want to give, credit for that. I feel more comfortable only giving the 75820 for the left side. Again, if you want to do that like more conservatively and only go with the 75820 on the left, that's fine. But here I feel like, okay, we've got 2 vessels. These codes are a little bit different from the arterial codes that we're accustomed to. Obviously there we typically look at the common, iliac and then down to the level of the femorals. But I did here go ahead and assign the 75822 for the imaging on the right and then imaging on the left. But again, if you wanted to go more conservative and just go with the left, that's perfectly fine. And then in our next paragraph, we see where it mentions an angioplasty was performed across the iliac veins and common femoral veins. And it mentions that the balloon is being used to cross the entire occlusion, okay? And then from there it says, I advanced a 30-centimeter infusion length catheter across the iliac and femoral veins. Thrombolysis was initiated from this location. So in this particular situation, this balloon is being utilized in order to help facilitate, this thrombectomy / thrombolysis procedure that the physician was considering. So it was actually utilized to help remove, part of that occlusion there. We don't have anything that is specifying that there's an underlying stenosis, that there's an underlying stricture. So we don't see any medical necessity for actually performing angioplasty in addition to thrombolysis or thrombectomy. So in this particular case, we're not going to code anything for the balloon because it was utilized to treat this occlusion, which then the physician moves on and then decides to place that thrombolysis catheter. So we have a venous thrombolysis that's occurring on day 1. So that is going to be coded with 37212. On our initial day for thrombolysis, we do report our catheter placement. So without having clarification from the physician here, I'm going to code 36011 for this portion of the procedure. And then you see I also have the imaging codes that I've assigned as well. So on day 1 during thrombolysis, you can pick up the catheterization codes, you can pick up the imaging codes if indeed the imaging meets the criteria for reporting diagnostic angiography, which I've talked about, multiple times in past episodes of Wildcard Wednesday. But when you get into those subsequent days, when you get into day, 2 and then day 3, and that, or whatever day you're ending on, those catheter placements, exchanges, and imaging, is all bundled in those other codes that you're reporting, whether it be for a continuation or whether it be for a cessation, that day that it actually stops. So that's what we have for day 1. When we come over to day 2, now we have the patient coming back for a thrombolysis check. And then it notes that there's a thrombolysis completion, a thrombectomy is occurring, there's angioplasty in the left iliac veins, and then we have IVUS that's also mentioned for the left lower extremity and IVC. So I'm going to skip over the clinical history because we already have an idea of what's happening with this patient. They're coming back now for the follow-up. And so here we see that the unifuse catheter, that was what was placed the day before, it's removed, and then venography was performed of the left lower extremity. So this imaging here is going to end up being bundled with whatever thrombolysis code that we're going to assign. In this case, the thrombolysis was discontinued. This is the final day, so that's going to get a 37214. So that venography that occurred there is bundled with the 37214. So any catheter work and any imaging bundled with 37214. Then the physician said, okay, I elected to complete thrombolysis. At this time, I'm transitioning to thrombectomy. So now we have the physician going on to use the Inari clot retriever in the next portion of the procedure here. And that is going to be reported with the thrombectomy code 37187. And then we see that that's used to remove a large amount of thrombus. And then the physician then goes on to say that IVUS was performed. So, well, let me back up for a second. So as far as the thrombectomy code is concerned, it's 37187. Sometimes the question will arise, why is this not a 37188? Well, if you look at the description of code 37188, that is for a repeat thrombectomy on a subsequent day of thrombolysis. So this patient didn't have thrombectomy on day 1. It was simply the thrombolysis being initiated. So that's why we're not going to do 37188 for this. This is an initial thrombectomy, so we're going to report 37187. Okay, so now the last line of the procedure report mentions that intravascular ultrasound was performed. and it mentions that it's performed of the IVC in the iliac veins, says there was compression of the distal IVC with significant variability with respirations consistent with hypovolemia. Then it goes on to mention compression of the common iliac vein, there. So IVUS coding can be like a little bit tricky. I personally like to see the IVUS findings kind of pulled out of the report on their own, if you will. And I like to see each vessel listed with the specific findings with the measurements from the IVUS service in particular to pick up those additional units of IVUS. Now there's an MUE on that. I believe it's set to where it's 5, if I remember correctly, on that particular code. But I see that it's actually the add-on code a lot of times doesn't get paid. It gets kicked out. It gets denied, even if you haven't hit like that MUE. And then if I'm looking at this from the auditor perspective, I'm like, okay, I have confidence that IVUS was performed, but do I feel comfortable based on this documentation assigning 37252 and then 37253, 2 more times if we're talking about the IVC, and then we're talking about the common iliac and then the external iliac vein. So here I feel like it's kind of iffy. Again, I like to see a list. I know there's one physician that I work with, like he actually creates a separate list where it says IVUS findings and will actually list each vessel with the measurements there separately in the report, in addition to mentioning it in the narrative. So that actually doesn't leave like any doubt there as far as like reporting IVUS. The other thing that makes it difficult with IVUS is that, okay, it's like, yes, IVUS is reported per vessel, but we also have to consider that it's reported per lesion. So while you can report it per vessel, the question is, do you have one lesion that's going across 2 vessels? Then it would really only be like one IVUS. So anyway, so here potentially, I feel comfortable with the 37252 and at least one 37253. If I'm going to give additional units, I would want to see better documentation, more clear documentation. Even then, with adding the 37253, I'm kind of like, I'd really want to see it look a little bit better there. But anyway, so IVUS, I try to code IVUS more conservatively unless I have like very clear documentation. And then when we go on to the next sentence, it says, I performed angioplasty across the iliac veins by inflating the Atlas balloon to nominal pressure to cover the entire iliac veins there. And now notice here, I'm adding the 37248 this time with using that balloon. The reason being is if we hop up a little bit above there, we see that it mentions a compression of the common iliac vein. So that's what I'm focused on. So if we have the compression of the vein, the thrombectomy's been performed, and now we have this compression of the vein, then we have the ability to report that 37248 to treat that compression of the common iliac vein. And so that's something you may see done on its own, where there's a vein compression, they may go in and they may open it up with a balloon. So anytime we see a balloon, angioplasty balloon being used with thrombolysis or thrombectomy, you always want to see, why are they using the balloon? What is being treated with the balloon? So as I mentioned, underlying stenosis, stricture, in this case, it's going to be compression. We will assign it if the balloon is simply being utilized to help macerate that clot, remove that clot. It's considered part of the thrombectomy and the thrombolysis, and you're not going to code it separately. And then you can even see in the impression here, it said there did appear to be at least a moderate iliac vein compression. However, revascularization with stent placement was deferred. So angioplasty was performed to treat the compression, ultimately decided not to place the stent for that compression. So the angioplasty was the only thing done. So our day 2 codes, we have 37214, which is for that final day of the thrombolysis. It was discontinued. We have our thrombectomy, 37187. We also can pick up the angioplasty code. And then again, the IVUS, depending upon, how strict you want to be about documentation requirements, you may potentially have 2 units on the 37253. So I'm kind of leaving that with a question mark. Again, I like to see more detailed documentation, when I'm auditing encounters, and I typically make a note of that just to make sure that we're not reporting more units than we should. So those are all of the cases for this week. I'm almost caught up on the cases that I have. I know I have cases for next week. I might even have some for the following week. I'm not quite sure. I might only have 3 like in the queue. I have to look. It's probably 3 or 4. So if you have any cases that you want to see featured on Wildcard Wednesday, please submit them. I'm going to flip up to the first page here, and you can submit them on the website. Here's the actual direct link, but you can just go to radrx.com, and then in the top right-hand corner of the web page, you'll see a contact us button, and you can click on that. And then you can fill out the contact form and then simply copy and paste the text of your reports. Make sure that you're not copying any patient information. I occasionally get physician information in it, and so I scrub that if I do get it before I put the cases on, but try to remove all of that, patient information, names of physicians, anything like that. If you can make sure that that's pulled out, definitely no patient information. And everybody's been very good about that. But I just want to remind everybody. So thanks again for tuning in, and I'll be back next week with another set of cases, and have a great week.